Hello, everybody, and welcome to our final topic for the fall 2014 semester for our online class for Introduction to Psychology. First of all, I want to say it's been a pleasure to be your instructor. I've learned so much from all of you, and I hope that you found the information from the semester valuable and you're ready to move on with your college career. Our final topic is on abnormal psychology. And I think it's really important for just a minute to talk about the difference between abnormal psychology as a field of study and the study of mental illness or the study of mental disorders or mental health. Now, they have a great amount of overlap. In fact, this activity is more of a academic understanding and an academic difference, but it's important to understand because when studying abnormal psychology, it's very tempting to assume that when you see an abnormal behavior, that equates to a mental disorder, and that's simply not true. We're going to start with what is abnormal psychology. Well, abnormal psychology is the study of what we call outliers. Outliers are those people who sit in a distribution of some variable. Let's say the one on your screen represents sadness to happiness. What we find is just as we learned in the research section of the class, is that any variable will generally move towards what we call a bell curve, with the population represented within that curve. And when we get to the outer edges, what we call the third deviation, we get to a portion of the population that sits out on the extremes of that behavior. When we're talking, for example, if we're measuring sadness to happiness, the people who look at extreme sadness, for example, are what we consider clinical psychologists. They tend to look at these things and want to know how they influence a person's behavior and mental processes, and how we can improve that portion of the population to move them up more towards the median. On the other end of the spectrum, when we get to extremely happy people, for example, we're talking about the study of positive psychology, which is the study of things when things go really right. They want to capture what happens when people are extremely happy. And their goal is to study these folks to see how maybe we can move the whole population towards that direction, or what sets them apart from, as you would say, the average. This study of outliers tends to color the field of psychology. In fact, when most students take psychology, they assume that it's all going to be about mental health and abnormal behavior and all those kinds of things. And it's due to a large part about our history with the influence of Sigmund Freud, who his theory was completely based on his clinical population, and he even generalized those clinical findings and tried to make general theories about human behavior, mental processes. And the humanistic psychology, which was largely based on the work of Carl Rogers, who was himself a therapist. And again, we see a major influence and a major defining feature of psychology is this study of abnormal behavior. When we look at the field as a whole, in fact, we find that clinical psychologists make up about 52% of doctoral prepared psychologists. And so it does make up a huge part of our field. But as you have, I hope, gleaned from the last 16 weeks, it's only a small part of what we do as psychologists. So with that in mind, let's start to explore abnormal behavior and mental disorders. So again, I want to emphasize, so what you see on this blue slide is a list of abnormal behaviors, okay? And it's important to understand that probably, maybe with the exception of violence, I hope that violence is nothing that anybody will have to experience or have had to. But if you look at all of these behaviors, these are all behaviors that we will experience sometime during our lifetime. We will all experience sadness plus elation. We all have a certain amount of repetitive behaviors. We've all been aggressive at a time. Hallucination is a common part of normal behavior. We all have a certain level of delusional thinking and negative thoughts, and there are times we do things that are not in our best interest, that are self-harming. We all get anxious, and we all have thoughts of harm. These are all normal human experiences that in and of themselves do not constitute a mental disorder or even constitute professional intervention, because they are a normal part of being this thing we call a human being. When abnormal behaviors start to become a concern is when those meet the criteria of what we consider as a mental disorder. And we're just going to define this. So if you take that list before, and we could probably add hundreds and hundreds of more descriptors, and we cluster those together, which we call a cluster of abnormal behaviors, and that cluster of abnormal behaviors become deviant, meaning they're not within the normal range for that person's age, gender, and situation. And they become distressful both for the person, but also the people in the person's life, such as spouses, family, parents, those folks. And that this deviant and distressful behavior is maladaptive to the person's life, meaning that it's counter-adaptive. It prevents them from holding a job, for example, or being successful in school. And probably the most important thing that defines also the idea of mental disorders is that it's persistent over time. If you look at, for example, the diagnosis of depression, it has to last at least more than 2 weeks, persistently over 2 weeks. And most disorders have a criteria for a minimal amount of time the person should experience those symptoms before they're considered a disorder. The reason behind that is, again, we can have a cluster of abnormal experiences, mood, behavior at once, but just because we experience those, if they're not persistent over time, meaning we successfully resolve them, they're not something that necessarily needs to be treated or something that will significantly impact our life for a long period of time. And additionally, we have to keep in mind that we will experience a lot of these abnormalities through life, but we all have different tolerances, and we all have different coping skills and resiliency factors that will determine whether or not those clusters of abnormal behaviors will become a persistent problem for a foreseeable future, in which then it's important to seek treatment. I think, as we stated a few times throughout this course, we do have some very early theories about mental illness. And just to put it in simple terms, for the majority of our history, up till about the time of Freud, when we actually started to see mental illness as much like a physical illness, that it is something that can be treated using naturalistic methods, medical methods, psychotherapy, those kinds of things. Abnormal behavior, or mental, specifically speaking to mental disorders, was seen as spirits possessing the person. So we get the idea of exorcisms. We get the idea of witch hunts in the 16th, 17th centuries. We get all of these supernatural explanations for these abnormal behaviors within the individual. And this is what really drove a lot of our history, and it still is with us today. You don't see very many people who like to admit that they have depression or they have anxiety issues, because that's not only seen as abnormal, but it's also seen as a moral issue, that there's something morally wrong with you, that there's something bad about who you are because you have this disorder. This comes from this early history of assuming that people who have mental illnesses were somehow inferior, and inferior enough to let an evil spirit possess them and take control of them. And that attitude still persists with us a lot today, even though we might not see it. As far as treatments, we also see the idea of physical treatments very early on. In fact, we see with the Mayan and predating Egyptian time the practice of what we call trephining. Trephining is simply a drilling the hole in top of the skull. Now, what they probably did not know at that time is if the person had a traumatic brain injury, they probably were doing them some good. Because we see trephining clear up through the Vietnam era, where a warrior would get a traumatic brain injury, so they would drill a small hole in the skull to let the brain swell out so that the brain did not squish itself inside the skull. But in our early history, that's not what this was meant to do. It was actually meant to release that evil spirit out of the person, and this somehow cured the individual. Unfortunately, it didn't work out so well for most individuals. Since our early our early theories and histories, we have developed some more modern-based theories, and if you go back to our conversations about Sigmund Freud and those early histories, that's where we get a lot of our current ones. This model here that you're seeing really kind of breaks down the major perspectives and theories about mental illnesses. So if we start with the psychoanalytic, or what's also sometimes called psychodynamic theories, this of course starting with Sigmund Freud and his crew, they truly believe that the mental illnesses are driven by unconscious drives that are not being satisfied in some way, or that there's been some injury or some insult to the unconscious processes that are going on. And this lends to the reason why a lot of people report not knowing why they feel depressed or why they feel anxious. And in an intuitive way, this theory makes sense because many individuals often do not know what's driving their mental illnesses. And so from an intuitive perspective, psychoanalytic theory makes sense. Where it starts to break down is today we recognize that we have both conscious and unconscious drives and processes, and it's probably a combination of both that really develop a disorder. The humanistic theory by Carl Rogers, who was the main push for this one, was a failure to strive to one's potential or being out of touch with one's feelings. If you remember early on in the semester, in fact, I think this was about the first week, we talked about how Rogers talked about the difference between the real self, who you truly are, and the ideal self, or that person you think you are. And the further those two are apart from each other, the more dysfunction we often see, the more depression, more anxiety, and those types of behaviors. The behavioral perspective simply states that maladaptive behaviors are developed through a learning and reinforcement history based on the environment. So they reject the idea that there's this internal drive or the failure to reach some potential state of being. And they also reject the idea that it's a biological issue. Pure behavioral theory states that disorders are a learned process. More modern concepts of cognitive theory focus on irrational and dysfunctional thoughts that are associated with many of the symptoms of many of the mental disorders. The sociocultural perspective is actually a newer type of understanding of mental disorders, and it's a really good idea to stop here and reflect on culture. If we go back to that list of abnormal behaviors that I gave you in the beginning of the presentation, it's important to note that those abnormal behaviors and the mental disorders that we are going to talk about are culturally bound, meaning that it is culture and society that determines what is abnormal and maladaptive behavior. So if you look in your textbook, for example, you will see the author puts a list of disorders that are recognized by other cultures, but they're not necessarily recognized in our cultures. Or they put a different spin or a different interpretations of disorders that we define here in the United States. So the sociocultural model really focuses on the dysfunctional society, what it is about a culture that develops that abnormal behavior within that cultural context. I think psychopathic serial killers are an excellent example of this sociocultural model, because psychopathic killers traditionally are a European phenomenon. The two countries that have the highest number of psychopathic killers are the United States and the UK. When we look into Eastern cultures, into Asian cultures, psychopathology has traditionally been very rare. In fact, we don't have a case of an Asian psychopathic serial killer, unless someone has been culturized into the United States, or accultured. So psychopathology is a good example of how abnormal behaviors are not only defined by a culture, but then those abnormal behaviors are maintained by that culture. The next level of analysis is the biomedical or neuroscience, and these people recognize that mental disorders are driven by biochemical imbalances, but they also emphasize organic and genetic predispositions. Now, again, I want to emphasize this from a course perspective, and it's really important to keep in mind. We can talk about how depression is associated with low levels of serotonin. But just because you correct those low levels of serotonin through medication, such as an antidepressant, you don't necessarily fix the depression. And so one thing I want you to keep in mind as you read about the biomedical and the neuroscience perspective is that it's not the entire story. And in fact, the way we often think about mental illness today is from a behavioral, cognitive, sociocultural, biomedical perspective. The buzzword for this is the biopsychosocial model, where we take in biological factors, psychological factors, and social factors to have a complete understanding of a given disorder. So these are different theoretical perspectives on disorders. I want to talk about a few assessment perspectives on how do professionals in the field develop an understanding of a given mental disorder, or specifically how do we assess for mental disorders. There are basically, and there are more, but for our purposes in this class, we're going to talk about 4 basic assessment perspectives. The first one is probably one of the more popular, which is a diathesis stress model. The diathesis stress model has kind of the assumption that vulnerabilities exposed through life events are what develop a mental illness. So the diathesis stress model states that we have basic vulnerabilities. You can call them genetic predispositions. You can call them lack of coping skills to deal with stressful events, those types of things. But what happens is that exposure to traumatic events over time start to develop into some type of dysfunctional way of thinking, behaving, and emoting. The diathesis stress model is used to explain, for example, the development of mental disorders such as post-traumatic stress disorder or depression and anxiety caused by divorce or by severe abuse within a home, all of those kinds of things, because the model is based on the idea that it's a maladaptive adjustment to trauma experienced in one's life. The more chronic the stress over time, the more the dysfunction you can see within the individual, according to this model. Social worker, if you're interested in social work, you will hear throughout your education this word family systems theory quite a bit, because it is the basic theory of social work. Basically what it says is that when you have an individual with symptoms of a mental disorder, such as depression, those symptoms are a reflection of a dysfunctional family system. Okay, so when you have a child within a home that is acting out, it's not that the child is a bad apple, as you would say. It's that the system or the barrel is what's creating the bad apple. So, therefore, social workers, for example, work on the family level more than the individual level. So with a child who is having issues, a social worker will help the family make sure they have food, shelter, warmth. They'll do parenting classes. They'll work with siblings. They work with the entire system, because from a social work perspective, it is the system that is broken, not necessarily the individual. The individual is just a reflection of the system that he or she is in. As we've talked, very close to the socio-cultural model that we talked about before, assessment at this level is the interaction between individual and their culture. And we find that individuals who have acculturation problems, aren't able to live up to cultural expectations, tend to have a harder time. Probably the most recognized and probably most well-researched model is a cognitive behavioral model. Now, this is an individual model. So family systems theory is systems. Diathesis stress model is life events. The sociocultural model is the interaction between the person and the culture. The cognitive behavioral model emphasizes the specific individual and how he or she has learned the maladaptive thoughts and belief systems which drive the individual behavior. Now, what you will find in your journey of studying mental disorders is this cognitive behavioral model has become very, very popular. And it has a lot of empirical evidence behind it, and a lot of therapies that are considered best practices are centered around this cognitive behavioral model. So from assessment to theory, I want to go into how we break down different disorders to understand them by talking about the difference between internalized versus externalized disorders. I'm going to start with externalized disorders because they tend to be the ones that are more easily understandable. So an externalizing disorder is a disorder that has a cause based on external influences. Okay, purely external influences. So, for example, drug and alcohol disorders would not evolve without the consumption of drugs and alcohol. And so you will never develop addiction unless that addictive element is put into the body. Okay. Now, so why are conduct disorder and antisocial personality disorder considered externalizing disorders? Mainly because they require what we call a toxic external environment for them to develop. So a child that acts out, or someone with an adult with an antisocial personality, doesn't develop in the context of a nurturing, healthy, happy home. In order for those two disorders to develop, you have to have a chaotic, abusive, stressful, unpredictable, toxic environment. And so conduct disorders and anti-personality disorders don't develop without those externalizing factors. If we go to the other side, what we call internalizing disorders, these are disorders that evolve from internal processes, or what we call internal emotional signals of either distress or fear. When we talk about distress, we're talking about things that concern the individual. When we talk about fear, we're talking about the perceived or the actual fear of something external to the person, or even sometimes internal to the person. So, for example, under distress, we see our major mood disorders, from major depression through dysthymia to general anxiety disorder, where one is a depressed mood, one is an aroused mood, but these are considered distress or mood type disorders. Now, you'll notice that anxiety is under distress, but we often, in kind of the lay language, we often think of anxiety and phobias and panic disorders as things that would be clustered together, but they're not. Generalized anxiety is a mood disorder, whereas phobias and panic disorders are a reaction to a perceived or real feared object. So a phobia develops out of a fear of spiders, those kinds of things. Panic disorders are disorders that are internally driven from senses of fear. We will get more into these as we go, but it's a good idea to keep these internalized versus externalized issues apart. We will focus mostly on internalized type disorders. The second thing that we should talk about is those types of disorders that kind of don't meet what we would consider having environmental and social and cultural influences, at least within our culture, or what we call organic disorders. These are mental disorders that have a very, very strong biological or organic cause. So, for example, the developmental disorders, which include things like autism or mental retardation, those types of disorders, they have an organic origin due to a maladaptive or a dysfunctional growth within the neurological system. Bipolar is an organic disorder because it has the majority of its underlying causes are biologically based, and treatments for bipolar have to include some type of medication intervention. Therapy alone for bipolar will not correct the disorder. Schizophrenia is another example that is what we call an organically driven disorder due to an overactive dopamine system, which causes the primary symptoms of schizophrenia. And there's a few other ones, but these are the major categories. So these organic disorders really fit into the biological model because they are going to need some other methods of treatment to correct them. Cultural and abnormal behavior, and I just want to emphasize this one more time. I brought it up just previously, that culture determines what is normal and what is not normal for a given population, and that cannot be overemphasized, I believe. Where I want to talk about next is a study that also looks into the issue of labeling, of diagnosis, of those kind of matters, because we need to really be careful when we look at diagnosis of mental disorders. And these studies come from the Rosenhan studies. Basically what happened is Professor Rosenhan and his associates, which made up, there was 12 of them to begin with, and basically these 12 individuals went to different mental institutions along the East Coast, and they presented malingering symptoms of hearing voices, and they were all admitted. All were admitted with the diagnosis of schizophrenia. None were exposed as imposters, but the interesting thing about this study is that once they said, wait a minute, this is part of an experiment, only one of them was released. When they said this was just part of to see what would happen, only one was released. The rest of them, it usually took either the president of the university or an attorney, and in some cases a judge, in order to get these individuals released back out of these mental institutions. But even when they were released, after admitting that it was just a part of an experiment, they all left with the diagnosis of schizophrenia in remission. And so here you have 12 individuals who were part of an experiment to see what would happen if you malingered symptoms, which means veined them, and then what would happen. These professionals within these institutions were so convinced that the individuals were just being manipulative that when they left, they put schizophrenic in remission. This raises some questions about mental illness, its diagnosis, its assessment, and what happens when labels are placed on individuals. And it's something we need to consider as we move forward in our discussion about what we do with mental illness and how we define it, and how we diagnose and assess it. The next thing I want to talk about just shortly is, should we medicate a disorder? It has been since the 1950s where we have had the kind of the chemistry revolution, where everything can be fixed through chemistry. And we see the development of pharmaceutical companies, we see the development of psychotropic medications, and all of these types of things. And we see a real push from the medical field and the psychiatric field to start to medicate our mentally ill. And that doesn't say, and I want to point out really quick that this is not a criticism of the use of psychotropic medication for the alleviation of severe mental illnesses. Those are some very appropriate applications of psychotropic medications, but we do have some modern concerns with it. And one example is after the Columbine shootings, the federal government held a mental health summit that concluded that medication of children in schools should be encouraged. And so we see in the later 90s and into the 2000s, I think every student in every one of my classes that have a school-age child has dealt with a teacher or a administrator who has suggested that their child be placed on some type of medication for some behavior that has been observed by the teacher or administration. This has been a policy through the Department of Education and the federal government ever since this mental health summit that they held on Columbine. Yet what we're finding is that medication has negative effects. Okay. Now again, I want to emphasize, while medications have their place, good places to begin with is, for example, for the beginning phases of depression, treatment of depression to help the person get out of that fog that they're in. Medication, very helpful. When an individual is suicidal or non-functioning, medication has its place. But in general, what we have found is outside of these areas, medication for mental illnesses or mental disorders has done more harm than good. And for the sake of the Psych 100 class, we can leave it at this. You can't artificially change the system without expecting the system to retaliate. And that when you adjust your biological systems with the use of medications, you should expect your body to respond in some way to bring it back to what it feels your biological natural state is. This, in case, can make it so the individual can end up in a more worse condition than in a better condition. And this is what we have found out for years of pushing medication onto people, onto patients, onto children, is we're finding there are severe and negative effects and continued effects that it has on people and on individuals. And so it's something that we have to consider. So I want to talk real quickly about a case study that kind of emphasizes this, this point. This is a case study of two autistic children, and the unique thing about these two autistic children is that they were born in the same town, approximately within a day or so of each other, and two different but equivalent socioeconomic families. These children were diagnosed with what is considered a moderate autism. Meaning that the symptoms are fairly pronounced and could have some maladaptiveness associated with them. Okay, the difference between the children is the way that the family approached the disorder. So for child one, the parents followed the treatment guidelines of medical professionals, which included medication, intense treatment, and continued medical evaluation. Child two, the parents used services to learn how to parent an autistic child, but they did not medicate the child or provided significant therapeutic treatment to the child, but instead they viewed the child's abilities as just being able to think differently than everyone else. So the biggest difference between these two children is child one, their behaviors and autistic behaviors were abnormalized, where with child two, the child's behaviors were seen as unique but normal. And so what happened 16 years later between these two children when they assessed them again? Which one approved? The modern treated as an abnormal disorder, or the one that says we need to help these children normalize and experience and understand their disorder? And what we find at age 16 is child one, the one that was treated according to a medical model, was reading at a first grade level, and his prognosis was that he was probably never going to graduate from high school, His ability to function on his own is that he would probably always need assistive living, and his IQ score was 40. Now, child 2, on the other hand, had a reading and math level of a 9th to 10th grade level, and a prognosis is that he would graduate in high school in 2 years. His ability to function on his own, the prognosis is that he will always have the ability to live on his own with little assistive needs, and his IQ score was at 90. Now, so what should we learn from this? And again, I want to really make sure this is just a case study, but it's to emphasize a point about the issues of labeling, the issues of creating abnormality within the individual minds, the issues of medication are not always the best course of action. And what we're finding more and more in the empirical literature is that we need to step back from shoving medication down people's throat by labeling them and all of these things and helping people overcome their problems instead of abnormalizing their problems. But that's this is almost a soapbox issue right at this moment. So let's move on and let's talk about some issues that are pretty important, at least within our area of the country, to understand. I want to talk a little bit more about this diathos stress model before we move on. The diathos stress model, again, life trauma has one of two effects on an individual's. Either life trauma will promote adaptation or it will inhibit adaptive behaviors. What this idea of life trauma is trying to state is based on, again, we'll say biological factors, social learned factors such as coping skills and how to react to situations, and cognitive factors that allow you to think and problem solve will either promote you when you experience trauma or will inhibit you and lead to the development of disorder symptoms and the potential of self-harm or suicidal behaviors. This is something we need to take a look at for just a minute, because trauma within a person's life, crises within a person's life, stress within a person's life, conflict within a person's life is important for an individual's growth and development. This idea goes back even to Piaget, who talked about cognitive development. He very much said that children need to experience conflict, crisis, and trauma because it's those things that promote adaptation, growth, and development. And so a child who is raised in an overly protective environment is just as susceptible to the development of mental disorders as is a child who is raised in an overly chaotic, inconsistent, and abusive environment. It's when, as most individuals today talk about kind of the responsibility of parenting, it's when a child naturally learns about the troubles of life and the experiences of life, and then is provided an environment that is set by the parents to learn how to think about, cope, and deal with those problems of the world that develop into successful adaptive children, that trauma does not have such a severe effect on that individual because they have had the opportunity to, in a safe way, learn how to deal with that trauma and those crises. Another thing that I would like to mention is that the severity of life trauma is subjective to the person. This comes from both the literature, but also I'll just give a professional experience. I once worked with a lady who went into complete crisis mode, meaning that she was having a crisis response almost as severe as someone who has just been physically beaten over a toenail being broken. Now, a lot of people might find that kind of silly, but if you learn about the past of this individual, you'll learn that that is a traumatic event for that particular person, and it demanded the same level of crisis intervention or crisis response as it did with an individual who has just been severely hurt. And this is what I mean. And we can see people who can endure a lot of trauma that have no crisis response to it. Okay, so the severity of life trauma is a subjective thing. Some people can tolerate, due to protective factors within their life, high amounts of trauma, whereas there's some people, because they haven't had these protective factors and coping skills put in their life, that low levels of trauma can have a significant effect. And that's important to keep in mind as we move forward. I want to talk for the next few minutes, and I would actually recommend that maybe you take a break at this point before we move on. I want to talk about a problem that seems to be very persistent here in the state of Montana. And in fact, I would encourage anybody is if you are making Montana your home and you very much want to be a part of your community and help your community grow and develop in a healthy way, I would consider looking into this topic a little bit closer. Because what I want to talk about for a little bit here is the issue of suicide thoughts and attempt. And again, the reason why I'm bringing this up as a matter of importance specifically for us here in Montana is Montana has consistently rated over the last 15 years as being in one of the top 5 states with the highest suicide attempt rates and completion rates. In fact, I believe last number I looked at, Montana rated number 2, number 3 for the last few years, with Alaska and Nevada switching first and second. So suicide attempt and suicide completion rates are a serious issue for Montana as a state to look into, but it's going to require not a governmental intervention. It's going to involve a community intervention. It's going to involve all of us to solve this problem here in our state. So I want to talk first, though, because these kind of things tend to be intertwined in many people's perspective, is first I want to start with the difference between suicide and self-harming behaviors. To be clear, suicide is an attempt to end one's suffering permanently, whereas self-harming behaviors, often called cutting, is an attempt to relieve suffering through the infliction of physical pain. And this is important to keep in mind. Self-harm is not suicidal behavior, but self-harming behaviors can lead to suicidal ideation. And if the infliction of pain no longer relieves the suffering of the individual, that can lead to suicidal attempts. Now, here's a key thing, is if you have a friend or a family member or a loved one who you suspect is cutting, it's important not to start off with a line of, "Do you feel like ending your life?" Because once you have said that, once you bring recognition to their cutting behavior, and then you associate it with suicidal behavior, you have just planted the seed for suicidal ideation and suicidal attempt to blossom and develop in the individual. Therefore, if you have someone in your life that you notice they're covering up more often, or that you notice there's cuts and whatnot on their arms, or in what we call the clothed area of the body, it's important to address issues such as how are they feeling, what's going on in their life, and encouraging them to open up to you. But it's a bad idea to directly approach the actual cutting behavior, because it's not the cutting behavior that is the problem. The cutting behavior is their current coping mechanism. It's the way they're dealing with the problem. The problem is somewhere within the way the person has conceptualized their world, their emotional world, their social world, and their internal world, that is causing so much emotional pain that the feeling of physical pain actually relieves that suffering. So, with individuals that you suspect that, remember that the cutting behavior is a coping mechanism, but to help the person, you want to address or try and help the individual figure out what is driving that specific coping mechanism. Okay. I want to now go to suicide assessment and risk assessment, and talk about this a little bit more. So I want to talk for just a minute about suicide risk assessment, just so that everybody in the class has some tools to deal with when an individual does come up to them and states they feel like harming themselves. And we're going to talk real quick about the difference between suicidal ideation and suicidal attempt. I would be willing to bet that most people who listen to this lecture probably have, at one time in their life or sometime in eventual of their life, are going to think to themselves, would life be better without me here? Those thought processes are just as normal as the thought processes we go when we think about wanting to slap someone who insulted us, but we don't. We inhibit that behavior. Okay? The thoughts of wanting to end someone's life is an unfortunate part of all of our existence. When, though, does suicidal thoughts become a concerning problem? And this is mainly when those suicidal thoughts start to become a solution to any problem that the person starts to have. So each time that experience, that person experiences a bad experience, they think that, oh, if I was just not here, everything would be okay. Each time they do that, that has a compounding effect to where the person reaches a state of what we call hopelessness and helplessness, where they see no other solution to life's problems or resolution to any problems other than ending their own life. This is the stage where suicidal ideation results in a potential suicide attempt. So when someone says that they feel like ending their life, how should we approach this for our loved one? And the following steps are kind of a way to gauge on what we should consider doing. And it's based on three elements. The plan is the first one, and whether it is vague or detailed, the second one is how realistic the plan is, and the third one is how lethal the plan is. Now, when we talk about the plan, about whether it's vague or whether it's detailed, this is really getting to, has the person been ruminating about the idea of suicide to the point that they have a very detailed plan of how to follow through with the act? Or is it just they have been thinking about it, it's on their mind, but it hasn't reached the point of formulation? So an example of a vague plan is someone coming in and saying, I want to drive my car off of a bridge. Now that's a serious threat, but it's vague enough that they probably do not need an immediate crisis intervention. There's other things that you can do to help this individual. However, as was described to me once, if you have someone who says, I know an area in the parking lot that is really dark. I know no one is around between 9 p.m. to 10 p.m. and I have a .38 pistol that is loaded that's under my seat, and I've looked up on the internet about how to make it so it was quick, and I know that no one would be bothered. Now, you notice the level of detail in that second story. That individual is one of those individuals that you will want to be calling the ER. Whether or not they like it or not, you probably at that point have the responsibility towards that person's life to get them the help that they probably will not want. But trust me, it's a lot easier to lose a friend for getting them help than lose a friend that you will never ever see again. And so when you assess that first level, I feel like harming yourself, ask, well, what have you been thinking about? And listen to how they've been thinking. The more detailed it is, the higher risk. The other issue is how realistic the attempt is. Can the person actually do what they say they can do? Now, in that first element, if it's a very detailed plan, you stop there. But if it's that kind of vague, you're not sure, this is when you would go to the second level about how realistic can they actually pull it off. So, for example, I did have an example of a person who said they wanted to go drive a car off a cliff, and they were quite serious and they were quite aggravated. And so it was kind of a moderately developed plan. The problem is the person didn't have a car nor a driver's license. And so was that plan realistic? Probably not. So we'd want to go to the next level of assessment. This next level of lethality, this is becoming kind of a more and more vague criteria as we see the way in which individuals have been ending their life lately. But in general, the lethality assessment is basically the higher level of lethality, the more likely it is the individual will follow through with an attempt. But traditionally, that has gone along kind of some gender lines that need to be taken in consideration. So, for example, historically, men have not been too concerned about how they will be found after they're gone. So they're more likely to use a lethal method that is messy, such as the use of a gun or a violent type of weapon. Whereas women, despite their feelings of hopelessness, helplessness, they don't want to leave a problem for the people behind to have to clean up. So they're likely to use a lethal method that doesn't leave this is such poor taste, but leaves such a mess for people to clean up. So high lethality among women would be highly lethal doses of an extreme medication, or the hair dryer in the bathtub. Those kinds of things would be considered highly lethal, mainly for female populations. But what I would say on this category is you have to take in what you know about the person you love, okay, or you care about, or your friend. If they're the type of person that has always been a caring and affectionate person, you should probably take that female line of lethality into consideration, whether the person is male or female. Whereas if they've always been kind of that non-affectionate type, you might want to take that male route. Okay. Another consideration to consider when looking at suicide attempt and suicide risk, this important consideration is understanding how individuals recover from severe trauma, especially when they have had a hard time with that traumatic event. This is when you have someone in your life that has had a significant impact on their life. We don't, as human beings, automatically go from that significant life event to complete excitement and everything is okay. Or conversely, we don't go along and then all of a sudden we're in the depths of hell and misery. When you have someone in your life that has experienced a severe trauma and they have a extreme fluctuation in behavior, whether positively or negatively, that's when it is most important to check in with that individual, because what we find is that is a period where either the person is preparing to say goodbye, or they have reached that bottom point where the end is their inevitable desire to become. And so when you have someone in your life, watch out for those extreme fluctuations in behavior and make sure you check in on them. Now, let's go back, though, real quick, because I just realized I forgot to put this. What do you do with this assessment? If the plan is detailed, realistic, and lethal, it is a medical intervention at that point. However, if it's on the other side of the continuum, it's vague, it's maybe they could do it, and the method isn't as lethal, that's where you can do things to help. You can elicit the help of your friends and family. You should keep an eye on that person for at least 24 hours. Do not leave them alone. And then after 24 hours is when they're at a better point, they see that people care about them and are there for them. They are at a better state to make a decision about what they should do about their feelings and behaviors, and it's more likely at that point that they'll go seek help. The important thing is after that 24 hours, that doesn't mean you can leave. It means that you should give continued support to that individual. So this is a major issue for the state of Montana, and I would encourage everybody. I believe it is January 28th at the college. They're doing what's called a QPR training to help individuals identify these issues and what to do about it when you have someone in your life. We don't have time to go over these case studies that I wanted to go over, so I'm going to talk really quick about suicide prevention and what you can do beyond being able to identify it and assist. And this list right here are some common things that we know are associated with the development of suicidal ideation. Now, I should put this in reverse. Lack of love, so as a person feels unloved, the more increase risk of suicidal ideation. Decreased social connectedness. on a continuum of social connection to loneliness, the less connected people feel with other people, the more lonely they become. That loneliness then can become a chronic state that can result in suicidal thought and ideation. Social exclusion and social rejection by family and community members. So creating a community of social inclusion is a prevention strategy. Strengthening a sense of community. We find that where there's high rates of suicide attempts, there is also a high rate of disconnect between communities, such as neighbors, friends, families, church, and civic organizations. We find more disconnect among these. Another prevention strategy is to reject the lone wolf mentality that successful person is completely determined by the characteristics or the disposition of the individual. This lone wolf, or this rugged individualism that we have in the Northwest, has detrimental effects on people's well-being, because we have to understand that our success is not always our success. It requires other people. It requires a community that supports a person's success, that supports a person's ability to do things, and that there is no island in and of itself that is completely made by itself and on its own. And we need to reject that idea that a person who is successful is because of that person's character or disposition. The other thing we need to do is care for those who are close to us. We never should be too busy to not say, I love you, or that I care about you. In fact, I would encourage everybody in this classroom that on a weekly basis, you text, you message, you call someone or a couple people that are really close to you, and just remind them how much you care about them. And use the words, I love you, and don't be afraid of them. It's only when we connect people to each other that we can slow the rates of suicidal attempts in our state. Recent analysis of suicides in Montana shows a couple things. One, that predict suicide rates in the state. One is living alone. The second is thwarted feelings of belonging, meaning family rejection and community rejection. Third one is failure to live up to someone else's expectations. These three things tend to be common elements in the state of Montana among individuals who have attempted suicide. And if you note, all of these things could have been prevented by a community that looks out for each other and actually cares for each other and understands that we actually need to support each other instead of rejecting each other. And so I would consider those things as you think about your place within your community and what you can do to help your fellow community members live a better and healthier life when it comes to this significant problem in our state.